brought up so many wonderful points that I hope my talk will be able to kind of highlight and resonate. This is part 2 of talking about irritability and challenging behaviors, really focusing on the medical perspective. However, it's so impossible to completely untie medical and behavioral, right? And so hopefully a lot of you guys got to see Dr. Butter's lecture that he did a couple weeks ago. This does go hand in hand as much as possible with that. And I even saw a couple slides from him. So we will go forward. So irritability, what is irritability? People describe it in different ways. Here's some of the symptoms or behaviors that we can see and potentially label as falling under the category of irritability. It's not this really specific criteria like we have when we think about something like ADHD or anxiety, where there's this really specific list of symptoms for us as providers, where we can check boxes to see if you qualify for a diagnosis. But we know irritability is really, really important. It can be common in individuals with autism and something that can be pretty significantly impairing. So really important to talk about and catch. It's really important as well for families and clinicians to work together to make sure we're identifying when irritability is really becoming a problem and what's causing the symptoms so we can get the most appropriate treatment. So you guys did a great job kind of talking through all kinds of different things that can lead to specific behaviors in that case vignette. Move on. Alrighty, so when is it a problem? If you look at that list of symptoms that I just had on the last slide, you might look at it and think like, okay, well, a lot of kids do those things from time to time, and a lot of adults do those things from time to time. But when is it really a problem? And I think that one way we can start to think about it is kind of figuring out how significantly impairing it is. So what is the level of impairment from those behaviors? Is it affecting them in the school environment, for example? So is your kid having to miss days of school? Are you having to go pick them up from school? Are they being removed from the learning environment and unable to participate in the activities the other students are participating in? That's pretty significant. Same thing at home. If it's really impacting your ability to have family time, to be able to just get through your daily routines, sleep, eat, those kinds of things you're doing at home. And then looking at leisure activities, have you guys, whoops, sorry about that. Have you guys been able to attend the same activities that you've been able to attend in the past? Is that something that is changing for you? Like an example of that would be if you used to be able to always go out to the movies or to be able to go out and eat at restaurants, and you're not able to do that anymore. Your kid's not able to spend time with the other kids, playing outside like they used to, then that's really impairing as well. All right. One way I think we can kind of start to think about this as we're deciding how significant our behaviors are having, or our child's behaviors are having in different environments, is thinking about how has it really affected your life? Have you had to miss several days of your work? Has your child missed days of school? If you are thinking about what bad means for you, which might look a little different for every family, how many bad days in the last week or in the last month have you had? And then what limitations has that behavior had for you and your family? Sometimes we start to develop a tolerance for things without really recognizing how significant the impact is. And I think that what we think of as normal can change and drift over time, and not always in a good way, right? So recently I had a family in the office just a couple weeks ago where I just asked the question, saying things were going great. So what have your worst days looked like since last time we met? And Mom said, honestly, things have been great. He's only punched 2 holes in the wall since last time I saw you. And I was like, oh, I'd like to kind of take a step back and maybe talk about that a little bit more. How much did it cost to have that repaired? And, this has been kind of ongoing, but I didn't even know this was happening. And they were so happy it had only happened twice in 3 months. And as we talked about it, Mom recognized, maybe I am normalizing these behaviors that are actually impacting us in a lot of ways. And we would actually like for that to be better. So how do we really start that conversation? I'd like hopefully to be able to provide a pearl or two for you guys if you're wanting to start bringing this up to your providers that you're working with in the medical field, because the conversations may not always be directly, these questions may not be directly asked to you, but there's a couple of things I think you can do to kind of help stimulate that conversation as well. Number one, I think just collecting data from your whole team of people surrounding your child. So any information that you can bring to an appointment that just shows what kind of behaviors you're seeing in different environments and how it's impacting the child in those environments, home, school, therapies, if they're a part of different teams, coaches, for example, might be able to provide data. Bringing in a tally sheet. I have had somebody bring in receipts where they were like making marks on the back to just show how often they were seeing these things in a given week. Picking that specific behavior. So I always like to set goals, and as specific as you can get in setting a goal. And a different patient, I had recently, I was thinking about as I was building this talk, this mom came to me with a very specific goal. She said his favorite thing is watching movies. He loves watching movies. We haven't been able to go to the movies in a year now. We want him to be able to enjoy attending a movie again without us having to leave because of his irritable behaviors. And so that's a very specific goal that we're working toward. And then also asking to set goals at each visit. So bringing that up if it's not happening. I say, hey, I would like to make sure we're talking about our goals again. This is what we said last time, and here's kind of where we are. Do we want to change those goals? Those goals definitely change over time. Is there a different school goal versus a home goal versus like a personal or a leisure goal? Again, kind of reassessing those at each visit. And I think it's okay to have, like when things are going great, to still have a goal. Sometimes that goal is we want to keep up this great work. We want to keep up how they're doing right now. So how do we stay in this lane, right? Sometimes that's also a very active decision to figure out how do we continue along this path because things are going great. That's still a goal. And then identifying, okay, we've got a problem, but what's causing this problem? You guys picked up on so many of these possible things that can cause irritability just watching the chat. Dr. Butter did a great presentation on talking about stress and anxiety, depression, fears, worries, phobias, even some medical concerns, and how all of those things can sometimes play together. It's often maybe more than one or two things that are causing this change in behavior. And what do we want to really take as a next step forward? Well, we might really want to start by figuring out what's causing it. And so I believe that Dr. Butter also said this. I'm just switching to one of his slides that I stole. The ABCs of behavior. We're looking at that behavior. What's the antecedent or what's coming before it? And what's the consequence or what happens after the behavior? And then collecting this data so we can try to identify, is it a medical concern? Is it something more behavioral? Is it, an escape mechanism? I just included this, certainly not to read it all to you guys, but just so you have it to reference. I think you'll have access to these slides later. Like this table gives you some examples of things that you may be able to identify as a trigger, things that you can modify for the antecedent, things you may consider modifying for the consequence. Just one example, if you look at transitions as the trigger, I know Dr. Butter talked about using visual schedules. Consequence, you may praise those successful transitions and calmly persist with change. So there's lots of different things to think about. And these are more of those behavioral causes of these. I'm sorry. Well, there we go. Thanks, guys. I know it's hard. Our computers don't always mute for us when we first join. And so all right. Sorry, I was going to ask you to take over the slides again, but I believe I have power again. They were being pretty sluggish, but it seems to be responding to me now. All right. So thinking of medical concerns, I, again, just love how broadly you guys were thinking in the chat. You've done a lot of the work for me by showing me how much you already know, how these things can impact your behavior. All right, so the most common culprits, I would say sleep and constipation for sure, top two. If I can get sleep under control, constipation under control, we can often see a huge change in behavior. It can significantly affect behavior. Other things we want to think about are things like potential side effects to other medications that the child might be on. I recently had somebody that it was a very abrupt kind of new change in symptoms. We're kind of systematically trying to figure out what was happening. We decided to stop an allergy medicine just to see what happened. Kid got the behaviors resolved. I think that it was the allergy medication kind of triggering that. And the way we figured that out was by mom bringing it to my attention. Like the only thing that's changed in these past 6 weeks is this new medicine that we started for his allergies. And everything else is pretty much the same. And so again, the parent kind of bringing that data forward really helped us there. And then I know Dr. Bennett mentioned this when she was doing the case presentation, but then thinking kind of head to toe, all right, medical assessment, what else could be going on? When we've got a significant change in behavior, instead of going straight into treating that with a medication, let's make sure there's not something else going on that would require some treatment. So just a few things that can't sit and go through every possible scenario, but certainly some of the things we think about as we're thinking of the head. Is there a headache, a migraine? If the child isn't able to let us know if they're in pain, are there pain signals that you can sometimes pick up on? Is it a super abrupt change in behavior that's maybe associated with other neurological signs? That's really concerning, and we would want to rule out, an intracranial lesion like a tumor or something like that. Sometimes, kids may get into a lot of caffeine, and so is it an overstimulation from too much caffeine intake? As we're thinking about eyes, ears, nose, throat, I think we talked about the dental abscess was a great example in this case. That's something you don't want to miss. That's definitely going to cause a change in behavior and a significant amount of pain. A corneal abrasion is scratch on the surface of your eyeball. That's really, really painful and can cause a lot of behavioral changes. Things like ear infection, strep throat, maybe some thyroid problems that can cause some hormonal changes. Thinking about your chest, heart, lungs, any issues there. If you listen and hear wheezing, is there an asthma exacerbation that maybe you couldn't really tell just by looking at them? So we think about the belly. We talked about constipation, the big one already, but there's a lot of organs in our belly, right? We've got our gallbladder, our appendix. Are there any other associated symptoms that might point us to the fact it could be something like that? Does their belly seem super tender when we try to do an exam? For girls who have hit puberty, if they started their period, is there a chance that they might be having PMS? Is this a cyclical thing? You hear moms say, once a month, behaviors are really rough. Maybe it's associated with that, and we want to treat that. Always keeping in mind that a lot of our patients can be sexually active. Is there, can we ask those questions and figure out, could there potentially be a sexually transmitted infection, a urinary tract infection? And then just moving forward to kind of looking at musculoskeletal symptoms. So arms and legs, are they using their arms and legs differently than they used to? You're noticing they've got kind of a different way of moving their body. Did they maybe pull a muscle? Do we need to check the skin really good? Make sure there's not a big rash somewhere or something that seems kind of itchy to them, like some psoriasis or eczema. I'll kind of stop there. I know I've talked about a ton of different things, but these are things that we really want to make sure that we're looking at before we go straight to just treating with a medication to target irritability. And so if any of these things are identified, treat it first, monitor behaviors. But let's say, hey, we've ruled out a medical problem. So when do we consider medications to target irritability? All right, I'm going to talk a little bit first about just some kind of general mantras, to think about as we're considering medications or medication changes. Number one, no skill in a pill. One of my mentors used to say that a lot. So that just means the medications aren't going to, teach emotional regulation skills, things like that, but they can certainly be helpful in attending maybe to therapies where they can learn those skills. They don't treat those core symptoms of autism spectrum disorder, and there is a limit to how much we can expect from medications. Meds are one piece of the puzzle, but it can be such an important piece for so many people. And so we can't discount it completely. And then also keeping in mind what that risk benefit ratio is for your child, or the individual, that you're caring for. That can change over time. Sometimes the risk benefit ratio kind of goes back and forth a little, right? And so that's why it's so important to keep those follow-up medication visits and reassess that risk benefit ratio at each visit. Okay, so some of the times medication may be helpful if there's safety concerns, so self-harm, harming others, significant impairment, like we talked about before, if there's incomplete improvement with other interventions. So if I've got, a kiddo and we've been maybe trying, families really don't want to do medicine, or we're trying our best not to do medicine and we're doing all the therapies and they make a certain amount of progress but kind of stall, sometimes medication can kind of help you move and make more progress as a next step. And then some specific behaviors that we plan to target. If we're able to identify, we really want to target, impulsivity or aggression related to impulsivity. That's something that we can really target as we're moving forward with medications. So we talked about that target behavior and how important it is to really monitor that. You can monitor frequency, duration, intensity of that behavior. I do really, really suggest monitoring and collecting data, because without collecting the data, it's really hard to know if the medication's having an impact. I think when we live with people and are with them every single day, sometimes it's hard to see a change. And I even noticed that myself as I'm working on my weight loss goals. Like, I see myself in the mirror every day and I think everything's, I'm either doing worse or the same, and I've lost 5 pounds maybe that week. And so that monitoring and collecting that data can be really helpful so we can see that full picture. And collecting data doesn't have to be hard. I'm going to show you a couple kind of simple ways to collect data on the next slide, but also there are some more kind of comprehensive rating scales that your provider may use. So a few examples are the Aberrant Behavior Checklist, the Child Behavior Checklist, there's a Vanderbilt, a Connors. What they use may really depend on what your provider likes using, or really what the target behavior is, because they all kind of look at different behaviors in a different way. These are just a couple examples of ways you may track behaviors. This first one is a school behavior tracking, looking at hitting and defiance. I know you guys can't see that real well, but that's what those trends are that the school team is monitoring in a kid. And sometimes I'll have schools send reports similar to this to me in the office, so we can kind of see what's changing and what isn't changing. This next one is one I like. I've had a few families use something similar. They have just found and printed offline where they're doing daily frequency of a specific behavior. Maybe it's, hitting the brother, for example. And you just make a little tally mark each time it happens in a day, so you can figure out how many times it's happening each day. And I just will use this as an example to kind of talk through a couple scenarios, but let's say 12 is kind of average as you're coming in and we're initiating a medication. And then you're checking in with your provider every couple weeks or couple months, and you come back in and now your average is 8. 8 is still a lot of times to be hitting your brother, but you've gone from 12 on average to 8 on average. That means we're heading in the right direction. So maybe there's still room for improvement. Maybe we need to adjust a dose or something like that, but certainly we're moving in the right direction, which is what we like to see and can help us kind of figure out what the next best step would be. The second scenario we can talk about is if the average you come in and you're still around 12. Well, there hasn't really been any impact on the behavior from the medication. And there's a few reasons why that might be happening. Either it's not the right medicine for you, or maybe it is the right medicine, we just haven't gotten to the right dose. So we do often start at lower doses and kind of move up gradually to make sure that the kids are tolerating the medication. And so we may just need to keep adjusting and monitoring for side effects and effectiveness. And then that third scenario, maybe you were an average of a 12, and then you come back to see me and you're hanging out around 15 or 16. Well, that is not what we want to see at all. That is the opposite of what we want to see. And that would mean maybe either this is not working at all for you and things are just kind of progressing, or is the medication actually causing irritability? Unfortunately, sometimes the side effects of the medications that we use to treat irritability are actually irritability. And so we do have to watch for that. And if we're making it worse, it's time to try something different. So what medicines do we consider? Now that we know we're targeting a specific behavior, what do we think about next? I would keep in mind these next few slides are really general and there's a lot of individual factors to consider. But the first thing I like to think about if we're looking to this algorithm on the right is, are there symptoms of untreated ADHD or anxiety? I know Dr. Bennett and Dr. Nowinski also talked about ADHD and anxiety in a different section of the series. And so I'm not going to go into a whole lot of detail there, but we definitely know that untreated or incomplete treatment of ADHD or anxiety symptoms causes some irritability in some individuals. And so if you have either ADHD or anxiety or a combination of both, right, make sure that treatment is optimized. That's kind of the first thing I like to think about is, are we treating that completely? If so, great. Moving on, we're going to try a medication to target irritability. You'll see here I have trial alpha agonists as a first step. Alpha agonists aren't, if you look for, FDA indication for treating autism-related irritability and aggression, the only FDA-approved medications are antipsychotics, specifically Risperdal and Abilify. But there's a lot of reasons you use medications that are not fully FDA approved for different reasons. Sometimes it's because it was, the studies weren't done in specific target populations for a variety of reasons. But we do start with alpha agonists often as a first step because it does have a nicer side effect profile in many individuals. It doesn't require laboratory monitoring. And so it can sometimes be a nice first step. All right, and then we want to think about if that's ineffective or only partially effective, do we want to consider an atypical antipsychotic? It's definitely possible that more than one medication may be needed, and it can take some time to figure out what's the best scenario for your child, the best treatment regimen. Thinking about things like available formulations. Does it come in a liquid? Does it come in a pill? How was your child going to be able to take medications? What's the schedule like? Is this a once a day medication versus a twice a day medication? If so, then, some families, it's harder to do multiple times a day for a variety of reasons. Is it cost effective? Is there a need for laboratory monitoring? These are all things we want to think about and know that it can take some trial and error. And that's why, I just want to reinforce parents truly are our partners in care to make sure that we're really getting the best treatment for your child. All right, I do want to talk a little bit specifically about alpha agonists. These are some pretty cool meds, right? They were originally marketed and studied for blood pressure and certainly have an effect of potentially lowering blood pressure. Also an approved, non-stimulant option for ADHD. They can be especially helpful in individuals with aggression where there's an impulsive component to that behavior. And so that might be, if that's really your target behavior, this might be a good first step. Alpha agonists we talk about are clonidine and guanfacine. You guys may have heard of these before, or you may have heard of them by their brand names. They both have short and long-acting versions. And so the short-acting version of clonidine is Catapres, the long-acting is Capvey, the short-acting version of guanfacine is Tenex, and the long-acting version is Intuniv. Clonidine can be compounded into a liquid, so that's good to know. That means you can really, titrate doses very carefully, and for kids who can only take liquids, that option's available. Otherwise, they do come in tablets that can be crushed. The same is true for the short-acting of guanfacine, but both long-acting versions, that Capvey and Intuniv, they cannot be crushed and they do need to be swallowed whole. All right. So these are medications that can show symptomatic improvement in hyperactivity and impulsivity related to ADHD, right? But also can help in cases where it's not just ADHD symptoms. Sometimes those explosive behaviors can be benefited by these alpha agonists. They do work by stimulating these alpha receptors in our brain, and that ends up changing the way our nerve impulses work and affecting a neurotransmitter called norepinephrine, and that causes relaxation in our blood vessels. That's why it causes a lower blood pressure effect, and can also provide, this norepinephrine can also provide a calming effect in the brain. There's some side effects that we want to think about. So even though most children and other individuals will tolerate alpha agonists without many side effects, there's some things that we do have to consider. Number one is drowsiness fatigue. This is probably the most common one that we see. We do know that clonidine is way more likely to cause that sedation effect than guanfacine. And so, as you may have heard in other talks, clonidine is a little more likely to be used at nighttime for sleep issues, and guanfacine more likely during the day, although certainly you can use clonidine. Some individuals respond really well to it in the day as well. It can cause a drop in heart rate and blood pressure, potentially leading to fainting and dizziness, though we don't see that often at all. Can cause irritability. That's what we're trying to treat. That's that kind of paradoxical effect, right? So if we see more irritability, we're not going in the right direction. Can also cause things like constipation, dry mouth, and those more serious potential side effects. That very rapid rise in blood pressure, if you stop a high dose suddenly, that can make you feel pretty terrible. I had that happen to a kid on vacation when they forgot their medication and just decided they'd wing it and not take it. Also cause blood pressure to go too low if you take too much. That can potentially be fatal in overdoses. And so just like with any other medication, making sure that you're keeping it put away in a location where only you can access it. In order to avoid any problems with blood pressure, these are medications we definitely want to start at low doses and move up gradually. And then we also need to taper off instead of abruptly discontinuing. All right. And so now let's just talk a little about the atypical antipsychotics. We talked a bit about the Risperdal and Abilify being the two that are FDA approved and indicated for autism-related irritability and aggression, but there's many others that may be used for a variety of reasons. I did see somebody in the chat earlier talking about Seroquel or quetiapine. That certainly is a medication we'll use sometimes as well if it's a better fit for that patient. These really work by normalizing levels of dopamine and serotonin in our brain, which can sometimes do wonders, right? I've had families when we've tried everything and we've started Risperdal. I had a mom last year who said, I think we need to rename this Rescue Doll. This was so helpful. Sometimes the change can be quite amazing. It can improve hyperactivity to some degree as well, and a possible decrease in some of those really repetitive motor mannerisms that may be causing some more impairment. So I'm thinking of times when it might be really making it difficult for you to complete schoolwork or things like that. They are available in tablets, liquids. Risperdal is available in an orally disintegrating tablet, which is just one that kind of melts in your mouth. Again, these are medicines that you really don't want to abruptly start a high dose or stop suddenly. Doing that can, if you're on, a higher dose or really even just slightly above low dose, like a medium dose, kind of that sudden stopping can cause some withdrawal symptoms that can be pretty uncomfortable. And so you do want to be cautious. That drowsiness too is something, starting at a low dose and moving up slowly, you can sometimes avoid that drowsiness side effect. Okay, so talking a little bit more about when we might consider these atypical antipsychotics. Anytime you're really having incomplete improvement with other interventions and you still really need some help with those irritable and aggressive behaviors, it's definitely time to think about starting an atypical antipsychotic. Safety concerns persisting, if your lower risk interventions are not able to be implemented for a variety of reasons, right? Some people may not be able to take other medications, for example, or you may not have access to kind of crisis behavior intervention services. They do require monitoring. They can cause some side effects. I've seen some already mentioned in the chat. Even though most people don't have significant side effects, it certainly is something where we want to watch the side effects pretty closely. And I think it's important for you guys as family members and caregivers to just know what to watch for. Number one, those metabolic side effects. Gosh, we got to watch for the increased appetite, weight gain. Those are fairly common. Some a little, depending on the medication, you may be a little more likely to see it with some than others. There is, along with that, an increased risk for what we call dyslipidemias, which is abnormal blood cholesterol levels. So it can make cholesterol high, it can make triglycerides high. So we want to monitor that with labs. Same thing with blood glucose or your blood sugar levels. We want to monitor that with labs. It can cause elevated prolactin, and prolactin is what causes us to produce breast milk. Women after they've had a baby, that's very normal. However, a 13-year-old boy, that's not as normal, right? And so that's something that if you notice that after starting a medication, you want to make sure you let your doctor know. And then it can also lead to some extrapyramidal symptoms. An example of that would be tardive dyskinesia, which is a very specific movement problem we monitor for when you're on this type of medication. So you might notice your medical provider asking you questions about unusual movements that have happened, since the last visit, anything that's different than your norm. So tardive dyskinesia can look like really stiff, jerky movements, often of your face or of your limbs, that cannot be controlled. You might even see it sometimes in sleep. It can look like eye blinking, tongue thrusting, things like that. And it's really important for us to monitor that because you really need to intervene because it can become permanent. It's more likely to see this problem if you're on a high dose or if you've been on the medication really long term. It's another reason we always like to reassess where we're at and think about adjusting the dose down if we have the opportunity to do so. This is just a schema of what that monitoring might look like with atypical antipsychotics. In addition to monitoring for those abnormal movements, we're also checking these numbers, right? So the fasting blood glucose and lipid panel, that's looking at your cholesterol, triglycerides, sugar levels. Get that right before we start the medicine, then 3 months after, 6 months after, and then every year unless you see a problem, in which case you can get them more frequently. That's what we recommend. I don't have many patients I'm able to do this on, and I think we recognize that we really might need to work up to obtaining blood levels. Sometimes labs can be a pretty triggering event for many of our patients, and so I tend to try to be understanding of that, and if we really need the medication started, while also working on a goal of trying to get the labs whenever we're able to do that, and making sure families know why we want the labs, and then checking BMI, so monitoring that weight gain over time. Okay, I'm just going to very briefly touch on other medications. I think, when we're looking at irritable and aggressive behaviors in individuals with autism, it's not a one-size-fits-all model. And so we recognize that maybe the medications I talked about, even trials of multiple different ones, may not be the best fit for everybody. And so here's a list of some other medications that could potentially be prescribed, and some of you might be familiar with them. They're also anti-seizure medicines. That's really what they're, the class of medicine that they fall into. And they do seem to have a mood stabilizing effect for some people as well. These are medications that are probably more likely to be prescribed by psychiatrists. That could maybe vary depending on the practice that you see. But most of the time, more likely to be prescribed by psychiatrists. And so for you as family members, I would say, if other treatments that your provider is giving you don't really seem to be working or seem to be only limited amount of work or amount of help for you, then you might consider saying, hey, I'd love to get a referral to a psychiatrist to maybe see if there's some other medication options available for me, because what we've done so far doesn't seem to be working. Okay, and then just some general medication guidelines. We really want to keep those target behaviors and goals in mind and do that behavior charting, or consider, I'm here at the bottom now, considering a use of those behavior rating scales. And asking your provider, hey, is there a way that you would like to monitor this? What's the best way for you to monitor that? And you can help each other out in that way. And then also look for opportunities to decrease or discontinue the medication. You may need to be the one to elicit this discussion, right? And so the goal is that we can be conservative with medication use. We want to be able to use the lowest dose of medication with the lowest number of medications. That is ideal, right? We also recognize some people need higher doses or more medications at certain times in their life, and that is okay if that's what you need right then. But we want to keep thinking about, as our skills are increasing and as stressors change. So an example, maybe you got through puberty and things are kind of calming down. Then maybe the need for the medication, or at least the dose of the medication you're on, decreases. And you want to think about, again, involving other team members in this decision making. So what do the behaviors look like in all the different settings? How do we get parents, other caregivers, therapists, teachers to all kind of work together to help co-manage the prescribing of these medications? And then as you're thinking about decreasing or discontinuing a medication, there's some other things you might want to think about. One of the common things that comes up for me with my families is, yeah, we agree we're at a place where we could consider decreasing medication, but we really think that this would be better to do over the summer, because we're scared to make a big change during the school year where it really might disrupt their learning. We'd like to be able to monitor them more closely over the summer. I think that's definitely reasonable. You guys want to be able to have input on that. Also thinking about what time of day, if it's dosed more than once a day, and evenings are typically harder behaviorally, you might think about it kind of coming down on the morning dose before you come down on the evening dose. And then how slowly do you want to adjust? I really think this is personal and involves a lot of different decision making between the family and their provider. But is that something that you think, yeah, we're ready to come down on this? Let's, make a weaning schedule and get off of this within the next several weeks. Some people might really want to come at it a little bit more carefully, say, I want to make a small change. And then when I see you again in a couple months, maybe we'll make another change then. That's also okay. All right. Here is my last slide, I believe. Places for you to get some support. There's several online resources, some Autism Speaks toolkits, specifically the Challenging Behaviors toolkit, and then the Should My Child Take Medicine, that medication decision aid. I love it. I use it all the time. I feel like I print it several times a week, but I do think it gives you a lot of really great tips and tricks on how to think through systematically what would make sense for you and your family. All right, I think I'm done. I think it's time to move